All right, I hope everyone had a great break. We're going to do our introduction for our PM keynote speaker, Dr. Thikkurissy, who is going to speak on management of immature PULP and traumatic and carious scenarios. Dr. Thikkurissy, DDS MS, is a professor and Robert Creedon Endowed Chair at Cincinnati Children's Hospital Medical Center. He obtained his DDS from New York University and his certificate in pediatric dentistry and his master's degree from the Ohio State University College of Dentistry and Nationwide Children's Hospital in Columbus, Ohio. He also completed the program in advanced education in general dentistry at Wright-Patterson and was active duty in the U.S. Air Force for 8 years as chief of pediatric dentistry at Ramstein Air Force Base in Germany. He was director of the predoctoral program in pediatric dentistry at the Ohio State University from 2006 to 2011, and the director of inpatient dental services at Nationwide Children's Hospital from 2010 to 2013. He is a diplomat of the American Board of Pediatric Dentistry. He was awarded in 2019 the Above and Beyond Doctor of the Year by the Aubrey Rose Foundation for his work with patients and families with special healthcare needs. He has published in the areas of morbidities, quality of life, and pain management in children. I had the privilege to train under Dr. Thikkurissy, who we candidly got to know as Dr. Bobby, during my residency at Ohio State. His kindness, humor, and knowledge is infectious, and he is a resident and patient favorite for sure. He has great knowledge in all areas of dentistry and pediatric dentistry, and I certainly learned a lot from him. He also has some pretty good dance moves and great jokes and a really good singing voice that could always calm kids or brighten a stressful moment. So welcome, Dr. Bobby. Thank you and enjoy.
All right. Thank you, Jeff. And thank you for really highlighting my natural sense of rhythm and my dance move, because that is something that I take a lot of pride in. So you'll see my email there at the bottom. So if at any point after the talk you would like to ask any questions, please feel free to email me. Today's conversation is going to be management of the child with a traumatized immature tooth. So this really covers a lot of ground, and we're going to be kind of jumping all over the place because I'd like to take this from a really comprehensive perspective. Not only the actual trauma, but the dental materials, the behavior, everything that goes into that. So as we go through, I do have my eye here on the chat sphere. So if there's any questions or comments that come up in the chat, I will address those as I'm going through, so I'm not ignoring. If I see something that's going to fit in later on, I may delay until I get to that, but we'll make sure before we take our break that we've answered all the questions you have this morning. I really did look forward to coming out to Sioux City and spending some time not only with Jeff, but just to see your beautiful area. I've never been to that area, so I was really looking forward to it. And obviously COVID had other plans, so we are making do with what we have. Hopefully the presentation doesn't lose any of its flavor and you still get something from this. So without further ado, we'll kind of get started. So this is obviously the clinical scenario that we remember from residency and that we dread in our offices, which is the child coming in with a traumatic dental injury. There's often so much to process in the immediate sphere as far as what to do right this moment. But then, as we all know, there's the long-term plan that can be very often multidisciplinary, going with orthodontics, endodontics, oral surgery. So there's a full range, periodontics in some cases. And so what I'd like to talk about today is really some of those considerations and what the role of really the primary care dentist is going to be for the family. The primary care dentist, the pediatric dentist, whoever is the dental home for that patient, really will end up quarterbacking a lot of the coordination that goes within all the other specialties. So if you are managing the child with the dental trauma, you're in it for the long haul. So if you have a child who gets injured, and most of the kids we're talking about today are going to be between 6 and 9 years old because they have open apices of their anterior teeth. So those children are going to need help with growth and development, potential orthodontics, potential endodontics, and as I said, periodontics in some cases. And again, the primary care dentist is really going to be the quarterback for those myriad of treatments. So this is kind of a brief overview of what I'm going to talk about. And my image here is the perfect storm, because dental trauma with an immature apex really represents a lot of moving pieces. And the primary care dentist, the one who sees that trauma initially and who's going to carry that family through the trauma, has a lot of things to consider aside from the actual injury. There's the behavior of the patient, the expectations of the parents, your availability to do any kind of pharmacologic treatment if needed, so sedation or general anesthesia, your comfort level in managing trauma. Very often with these patients, many endodontists kind of shy away from these patients because of the potential for negative behavior. And as all of you know out there, general dentists are really the backbone of providing care for kids. And so general dentists are the ones who learn that behavior management and how to help not only the child, but the family. So we're going to talk a little bit about historical context, where we are in 2020, where we've been, behavior, families, apexogenesis, revascularization, lesion sterilization, and tissue repair, which is a newly kind of developing field, bioactive restorative materials, and then finally we'll touch on the issues of multidisciplinary care. So from historical context for what we call the hopeless tooth. So this is a tooth that, let's say, has been avulsed, so knocked completely out of the mouth. The family comes in, it's in the kid's pocket, it's totally dry. It's been dry for 3 hours. It's really a hopeless tooth. This study out of Canada at Toronto Sick Children's in 2004 is really instrumental and seminal in understanding the mindset of families that are coming in this situation. So Nguyen, Kinney, and Barrett looked at patients that had previous implantations of avulsed teeth, and they went through different scenarios, and they asked them, even after all you've been through, the amount of money that you've spent, would you have reimplanted the tooth? So even after having gone through the painful experience of replantation, the demands of recall for trauma, in some cases extraction, general anesthesia, sedation, the majority of both patients and parents said they still would have made the decision to reimplant the tooth. And about 50% of parents stated that they would still be willing to pay over $1,500 out of pocket to save that incisor. Parents rated retention of an incisor as significantly more important than the risk of infraocclusion. So I think that is incredibly valuable to remember, which is, even in the hopeless situation, parents would like the tooth put back in. Kids would like the tooth put back in. And we are getting to a point where some of the therapies that we have are able to prolong the life of the tooth. So obviously, from a growth and development perspective, the most significant issue is that we cannot place an implant in an actively growing child. The implant will not move with the child's growth. And so very often the implant will end up in infraocclusion in the maxillary interior. So if I place an implant in an 8-year-old, let's just say, remember from ortho training, the child's face is going to grow forward and down. Well, as the face grows forward and down, the implant does not move with the growth. So the implant actually intrudes, which can lead to questionable aesthetics. The families in this study would have preferred infraocclusion, either from the implant or from ankylosis, replacement resorption, as opposed to not reimplanting the tooth at all. So I tell my residents that if you're ever in doubt, even if the tooth is a complete long shot, if you can, replant the tooth, stabilize the child, and we can always talk about removing the tooth at a later date. If the prognosis becomes significantly worse, which is what we would expect, we can have that discussion. And we're going to go into other value of doing that kind of treatment. So return to normalcy is the parent's big key. Now this is actually a World War II picture, but after the hell of World War I, the American population voted for Warren G. Harding really on the platform of return to normalcy. We've gotten through all this. We just want to get back to normal. And you'll see as we talk about this, that is a driving feature for the parents and the kid. We just want to get back to normal. And so your job is to lay out the expectations as we move forward in treatment. So this is really the clinical issues we're going to consider today and how I'm going to frame this discussion. And I'm using my friend Peppa Pig as the example. So we're going to have a young child, typically younger than 8 years old. We're going to have recent dental trauma, very often a pulp exposure, a behavior where the child is scared and is crying, parental pressure related to the appearance of the tooth. And we're going to get into that appearance is going to be related to parental guilt. The parent's also going to feel very guilty about what the trauma may have been. The child self-esteem related to aesthetics, we'll talk about that. And really the clinical meat of what we're going to talk about is pulp management, restorative management, and behavior management. So how do we actually address this, not in a vacuum, but in a real clinical scenario that presents to our office? So first off, let's talk about the fact that we have a young child, often less than 8, with recent dental trauma. When we look at the epidemiology of dental trauma, we know that there is a biphasic curve. And what that means is there are actually 2 peaks of where dental trauma occurs. The first peak is in that 2 to 3 age range where the child is learning to walk and ambulate. So we may see that kind of primary tooth injury. Sorry. Then there's a second peak in that 8 to 14 age-year-old who has sports-related injuries, which can affect up to a quarter of this population. So sports can increase the risk of TDIs, which are traumatic dental injuries, due to falls, collisions, contact with hard surfaces, i.e. the floor, a hockey stick, a lacrosse stick. High-risk sports include football, baseball, basketball, softball, soccer, hockey, lacrosse, martial arts, rugby, and skating. Now, I am, in my anecdotal experience, going to add something to this list of high-risk sports, which is cheerleading. I have seen some of the worst injuries to a child related to cheerleading, being tossed up, not being caught. I mean, just the types of maneuvers that are going on, elbows and knees able to hit other people. So I would include that as well. Now, in the US, baseball accounts for the most dental injuries in children ages 7 to 12, and basketball has the highest rate, 13 to 17. So definitely, if we have children playing basketball and baseball, we want some type of mouth protection. Bicycles, trampolines, riding equipment, and playground equipment can also increase the risk of traumatic dental injuries in children. And something that there is increasingly more of are these trampoline parks where they combine trampolines and basketball so that kids are not only on the trampolines, but they're also now, they have all the injury risks from basketball, which just seems like a horrible idea for any kid to be involved in that. But it has gained a lot of traction, and there's a lot of places I know here in Cincinnati. We've had 3 urban air trampoline parks increase in really just the past year. So predisposing risk factors also include the individual anatomical features. And this is obvious. We know that when there is a significant amount of overjet, maxillary protrusion, inadequate lip coverage, so the child is bimaxillary protrusive, has, is unable to close their mouth, anterior open bite. Overjet of 3 millimeters or greater is responsible for a 5.4 times higher risk related to dental trauma. Typically, the maxillary centrals and the maxillary laterals are the most common teeth, but I have seen mandibular anteriors as well. Sports-related dental trauma involves the upper lip and the maxilla in up to 90% of injuries. Uncomplicated enamel fractures, which means no pulp exposure, followed by uncomplicated enamel dentin fractures, are the most common types of traumatic dental injuries in the permanent dentition. Whereas in the primary dentition, typically luxation injuries, child falls, the tooth gets pushed back, is the most common injury that we see. So these are just some photo examples of kids that we might see in our hygiene practices where that overjet is excessive. And again, we may find that these kids are more prone. This is an intrusive injury where the tooth is intruded or pushed in almost completely. So the kind of universal solution we typically turn to is mouth guards. Up here we have a picture of Steph Curry not wearing the mouth guard as he should. And I see so many athletes letting it hang from their helmets or just kind of chewing on it and not maybe having it properly placed or deforming the mouth guard while they are wearing it because they're kind of moving it around, chewing on it, etc. So according to the American Dental Association, collision and contact sports are significant, but you can also get injuries in gymnastics, skating. In kids like me who are extremely uncoordinated, I need a mouth guard to play chess. So you may see that as well among some of the populations. But the concern is, are we really going to make our gymnasts wear mouth guards? We should, but sometimes there is a lot more pushback on wearing those mouth guards. Now, when athletes selected a boil and bite mouth guard, which is just like it sounds, you put it in boiling water, you warm it up almost like impression compound, you put it in the mouth and you mold it, and the saliva essentially hardens it as it cools down. When players selected their own mouth guards with these boil and bite, 75% of players had oral lesions located in 3 primary areas: the gums, the cheek, and the roof of the mouth. And this is typically from an ill-adapted mouth guard that is now traumatizing the oral mucosa. By the end of the season, almost 100% had oral lesions, not only in those areas, but also on the tongue. So now as we continue on, we've talked about the young child who we're dealing with and the kind of epidemiology of dental trauma. Now we're going to talk a little bit about the fact that we may have a pulp exposure. So one of the thoughts with pulp exposure is direct pulp capping or a pulpotomy. The classic management for an open apex tooth that has had a pulp exposure is what's called a SVEK pulpotomy, CVEK. Excuse me, a SVEK pulpotomy is synonymous with a partial pulpotomy. So the point here is you have this injury right here, and you go in and you remove the superficial 1 to 2 millimeters of pulp that has been exposed to the trauma. You get to healthy pulp, and when you get to healthy pulp, you place calcium hydroxide powder directly onto the pulp, a glass ionomer over that, and then you restore the tooth. That is the classic SVEK pulpotomy that was originated in the 1980s and 90s. We now, and we're going to talk a little bit later, have many different materials that we can use. When I am doing a pulpotomy, a SVEK pulpotomy, I still use calcium hydroxide powder. It's a wonderful medication. It's very, very basic or alkaline. So it has that antibacterial property. It's very easy to place. Some of the MTA products, and we're going to get into MTA or mineral trioxide aggregate, can cause discoloration. I am less prone to see discoloration with placing calcium hydroxide powder. Now, in his original article, SVEK noted that if there was a traumatic exposure, the pulp reacts by actually becoming fibrotic in that superficial 1 to 2 millimeters of pulp tissue. So SVEK actually said that you can go up to 90 days with an exposed pulp because it will fibrose over. Now, that's very rarely going to be the case. You're very rarely going to let a child go that long in the case of a pulp exposure. Exceptions to that might be a child who's in a really significant motor vehicle accident, who has cervical spine precautions, is not able to move. We might want to tell the parents, we're just going to wait and monitor and let him get stable, and then we'll manage the tooth. So here at Cincinnati Children's, we do have an endodontist that we work with, helping our residents with dental trauma. We see anywhere from 2,500 to 3,000 dental traumatic injuries every year. And when I say we, I'm there as an attending who signs off on the chart. The residents see them day in, day out. Direct pulp capping from our endodontist is typically indicated when the pulp exposure is 1 millimeter or less. So a much smaller pulp exposure. I still personally prefer to do a SVEK partial pulpotomy to just be able to remove all of that inflamed tissue and have control over how I'm maintaining the seal of the pulp. So this is an example of a complicated fracture. So one that has a pulp exposure. Now this pulp exposure is relatively large. So I would plan this for a SVEK partial pulpotomy. Typically we look at the different treatments, and what we find is that the pulpotomies have a better chance of maintaining vitality than the pulp caps. So that's what we're looking at. And this is from the International Academy of Dental Traumatology. So this is kind of the classic SVEK pulpotomy. So in this first picture, we have a pulp exposure. We've actually prepped, made a preparation. We've put no medication on the pulp. What we have done is we take a damp cotton pellet, we pack it into the chamber, and we leave it with pressure. And what that does is that actually helps hemostasis, and you will get a glossy red pulp that is not actively heming. So it's also important here, as I said, a moist, a damp cotton pellet. If I put a dry cotton pellet and pack it in, the tendrils of the cotton pellet will actually go into the pulp. So now as I pull that cotton pellet out, it's going to start bleeding again. So ideally, a damp with just sterile water goes into the pulp. Next, we have the second slide, which shows calcium hydroxide powder being placed to cover the pulp. That powder is in direct contact with the pulpal tissue. And the third picture is the placement of some type of a glass ionomer that goes over the calcium hydroxide to essentially maintain or protect the calcium hydroxide and the pulp. Now, one thing that I don't have a slide on, but we really should talk about this, is the American Academy of Pediatric Dentistry, the American Academy of Endodontists, all recommend that anytime you are getting into the pulp, you are using sterile water. In fact, the AAPD goes so far as to say irrigating with sterile water rather than using an air water syringe. And the thought process is that probably about 2 or 3 years ago, there was a rash of mycobacterium infections related to pulpotomies in both California and Georgia. And the thought was, what happened was there's mycobacteria in the lines that was then placed into the pulp, causing these infections. Multiple children were hospitalized, and the common feature was that they all had pulp treatments coming from 1 or 2 specific offices. So with water management, anytime we're talking about pulp treatment, we really should be using sterile water. So a question is, can you use dical instead of calcium hydroxide powder? Absolutely. Now, the dical does have the way it's formulated, the release of calcium hydroxide is not as plentiful as from the calcium hydroxide powder. So the powder is more ideal, but dical, if you don't have anything, dical is not going to harm the patient. So what we are looking for when we talk about management of an immature pulp is we are looking for what's called maturogenesis. So maturogenesis is not only that we get apical closure, but that we get adequate thickening of the dentinal walls to make sure that this tooth has long-term viability. So SUPRA-CEJ restorations and discoloration going back to this slide, you can see there's a little discoloration here. So some of these materials will have either silver sulfide and bismuth. Silver sulfide and bismuth can cause discoloration. So if you use MTA that has bismuth in it, it can contribute to this kind of dark discoloration. So another question is sterile water better than saline solution? Sterile water is what the recommendation is from the AAPD and the AAE. Now, having said that, saline is going to be better than water from your air water syringe. So if you have sterile water, that's great. In fact, a lot of the materials that we'll talk about come with their own little ampules of sterile water, which is for mixing the materials. So in some cases, you can use that as well. So silver sulfide and bismuth can contribute to discoloration. One of the newest products on the market is the New Smile Neo MTA Putty. The initial reports on that are that it causes minimal to no discoloration. It is something that we are planning on really going to here as well. So we've all ordered our samples of it, and we have a webinar coming up with them. So New Smile Neo MTA is something to consider as a potential future kind of standard material. So any intracanal restoration or medicament, whether it's for revascularization or traditional fill, should be placed below the CEJ. So you can see kind of the discoloration, and if the CEJ is right here, this material is slightly above the CEJ. So in an ideal world, the way you would detect this is you would take a perioprobe and you would lay the perioprobe out here and measure that CEJ. So let's say I measured it, and from the incisal edge to the CEJ, it's 10 millimeters. Then when I go to my access, I want a minimum of 10 millimeters between the incisal edge and my restorative material. So that is something that we have to pay attention to as we're restoring these teeth, even temporarily. So if you, yes, yeah. So a question that comes out is, what about antibiotics? Should I prescribe antibiotics for kids who've had dental trauma pulp exposures? And what the International Association of Dental Traumatology says is that the value of systematic antibiotics is inconclusive. There is intuitive sense to say you are supporting an immune insult, and so you can do it. It's of minimal harm, but it's not an absolute you must do an antibiotic. Now, I think what you need to weigh is the risks and benefits of the antibiotic. If I have a patient that has multiple allergies, am I risking a allergic response? If I'm using an antibiotic such as clindamycin, can I cause any kind of long-term GI problems with the clindamycin? If I'm using something like vancomycin, you know, these all have long-term impact on the GI system. So if you are using antibiotics, the choice is the antibiotic of choice is still penicillin, PenVK. Now, This statement says amoxicillin or penicillin remains first choices. I'll ask this, and just if anyone wants to comment in the chat box, does anyone know why we might choose amoxicillin over penicillin? I will tell you one of the advantages of penicillin. Penicillin, there is something where the inhibitory concentration, the MIC, minimum inhibitory concentration, at what dose, at what level does the antibiotic begin working at the lowest? Penicillin, PenVK, starts working at a lower dose than amoxicillin. So penicillin still is really my first choice. I will go to amoxicillin because the penicillin dosing is QID. So if I have a child and I'm not sure about compliance, I will use amoxicillin, which is TID, to help with the dosing compared to penicillin. That's really the main reason that I would go to amoxicillin over penicillin. So there is also the tetracyclines, specifically doxycycline, which is often recommended for dental trauma cases. It is important to note that in any child 12 and under, there is a risk of intrinsic tooth staining. So if that child is dentally delayed, doesn't have all their teeth in, and you use doxycycline, you could get staining of the premolars. Doxycycline is often recommended because it has its highest concentration in the gingival curvicular fluid. So that it's really a very, very localized delivery of the antibiotic. Are there any questions on anything that we have talked about so far that have not been answered in the chat boxes? Feel free to type in anything you'd like to ask. So now we know we have a young child, we have dental trauma, and we have a pulp exposure. So now the next piece is that we have a child who's very scared, very often crying from the trauma, and we have parents who are going to be frazzled and stressed as well. So the fog of war. What this relates to, and many of you who've treated dental trauma understand what I'm saying. The patient comes into your office, the child is upset, the mom is upset, everyone is just freaking out because of the trauma. It's not always a good time to make definitive treatment decisions. And so that's why if I can put the tooth back in, I'll put it back in, even if it's going to be poor prognosis, because we can always talk about that later. Somehow I feel that if I say, no, I'm not putting this in that moment of the fog, those parents are going to be really upset, are going to, take a much more adversarial position to you than as someone who's trying to do what's best for the child. So child behavior following a traumatic event, consider the developmental age along with the response. I may have a 4-year-old. Well, that child could be developmentally delayed. They could be a 3-year-old developmentally. And that is really going to make it very difficult when I'm doing my traumatic kind of conversation. If I have a 7-year-old, are they developmentally a 5-year-old? How are they communicating? Are they communicating normal for a peer of that age? So consider developmental age. Consider the parental trauma as well. If you have a child and your child has ever fallen, there is that pit in your stomach that is, so worried about everything. So the parents are going to come in and they may be really on the offensive. The parent and the child are very often going to replay the memory. Oh, I'm so sorry. I can't believe you You fell. I should have never let you go on the slide. I remember seeing you on the slide and thinking to myself, this isn't safe. So you're going to have to pull out your psychologist hat, and you're going to have to talk the parents and the child into a place of less anxiety. Children will have nightmares in some cases related to the trauma. If it was related to a motor vehicle accident, absolutely. A bike accident, anything like that. Fear, anxiety, sadness, anger, all of those are going to be there. If I'm grandma and this happened on my watch, I'm going to feel so guilty. And the parent, especially if it's not that parent's parent, is going to feel really ready to blame that other person. And I think one of the worst things is you get into the situation where everyone is kind of debating what happened while you're trying to take care of the child in your chair. The child is going to realize that the world is a dangerous place, and this could lead to distrust. Maybe mom or dad said, this is no problem, this is going to be fine, you're going to be okay, and then this happened. These kids who have trauma, have had traumatic events, have a lower startle threshold. So in some cases, you may go to put the chair back, and that's going to startle the kid, and kid starts crying. So my recommendation is have the chair laid back, let the child get into the chair so there's no sudden movements and no startling. And remember that this patient, and to a degree the parents, are going to see danger in everything. Okay, papoose, local anesthetic, anything you have to do, that there is an element of danger with that. So one thing I want to go back here, which is really important, is the family comes to your practice. Do not proceed with treatment until the child has been cleared for closed head trauma. So if the child, could the child have had a concussion, anything like that? You really want this child evaluated before you get heavily into treatment. Now, in some cases, that means putting the tooth in the Save-A-Tooth, getting an ED consult, or if you have a neighborhood pediatrician who's near you, letting them rule out a concussion or any incidents of closed head trauma, because you don't want to get into the treatment and then have the child pass out. So this is a quote from a child who had an injury. And Sam said, "Is my dad really upset because I've lost my teeth?" The parent is saying, we said we'd rather he broke his arm. At the end of the day, that can be fixed. How is that going to help this child feel better? So it's really important to note how parents are coming in. And the parents are going to come in judgmental. Let's say that they were out riding their bike with a friend. Parents are probably going to blame the friend. You're going to have to diffuse a lot of drama as you are treating this family. Guilt linked to the expectation that parents should be able to keep children harm-free and safe. It's important to note that kids are resilient. Open apex injuries are sometimes, if I had to choose, the best type of injuries, because a closed apex may not respond as well. Young kids heal much better. This quote from Dr. Wittenberg: if a child senses that you feel horrible, they will start to absorb those feelings about the incident. If you apologize, give hugs and kisses, and move on, they are likely to move on too. So how will parental guilt impact their desire to have care done in a non-ideal setting or type of treatment? I want you to replant it. Well, we did talk about that it's always easier to replant and remove later. I don't want them to cry. I don't want the papoose. I want you to knock him out and treat him. I don't want him to cry. You may not have access to general anesthesia capabilities, and the child may have to be referred somewhere else if that is truly what the parent's options are. You may have to refer them to the ED right away because the parent doesn't want you to do anything and you can't work with their restrictions. So the challenge for us as the dentists, the dental team, I know we may have some hygienists and assistants on there, is reframing the priorities. The child is going to focus here. What happened? It was horrible. I remember it. The child is upset. The parent may focus on what is going to happen. Are they going to lose their tooth? How could this happen? Why are you not putting him out under anesthesia? Your job is to get everyone on the page of what are we going to do right now to make sure that this tooth is stable and that we can give the child the best prognosis moving forward. So now we have a clinical issue that we're going to consider, which is this child's self-esteem. And a lot of what I've been talking about is setting up the treatment. And the reason I'm not jumping right into the trauma management is understanding that this is a family and this is a child. And you have to do all of these other things before you even get to the tooth itself. So prepping your team, making sure everyone understands that we're being supportive helps your treatment go much better. So, I put this in because it's definitely a concern of parents. Bullying. If my child fractured their front teeth and now they have to go back to school and you're not going to do a buildup, you just put a temporary, how is that child going to be handled by their peers? How resilient is that child going to be? Social judgments can be made in relation to facial appearance and dental appearance. When people were asked who should tackle cyberbullying, really it was users that were the ones most people thought responsible and having the most power. Those users are 8, 9, 10, 11-year-old kids. Parents only have 20% of people saying they have the power to tackle cyberbullying. So we're really wanting to set that kid up in a good place, particularly if the child is in that prepubertal age where they're so concerned about being normal and appearing normal to their peers. So this was a study by Rod and Noble in 2019. And what they did is they looked at kids who had fractured incisors, and they showed other kids these pictures. And what they found was that kids rated photographs of a normal dentition more positively than the kids who had the traumatic dental injury. Appearance-related teasing and bullying is an increasing concern, and undoubtedly this is fueled by the ubiquitous use of social media by young people. So that is something that you want to address and consider when you are talking to your patients. So this is another quote from that same paper as before. After treatment, his whole outlook became lighter and he began to assume the confidence previously lacking. His appetite improved. There was a gain in weight and now he slept well. His position in the family was reestablished, and shortly afterwards, he was reinstated as the choir soloist and has been successful in his scholarship to a public school. Now, I'm not saying you're going to change every child's life, but dental trauma definitely has that potential to completely take a otherwise well-adjusted and healthy kid and turn them around. So it is something that we need to consider. All right, so let's see. Do you mean if that a child comes in with an avulsed tooth that needs to be reimplanted, we shouldn't do it until the child is evaluated by an MD for head injuries? Fantastic question. So my feeling is if you start getting into the treatment, local anesthetic, splinting, and you had a significant injury, you are assuming the risk that the child could actually pass out, particularly if you start using nitrous oxide. So in an ideal case, we, open apex, we want it in Save-A-Tooth or milk, and we want them to come in as soon as possible. But what I would do then is, if they're in your office, I would call the ED myself, and I would have the conversation and say, here's what's going on, so that the physician can tell you about any warning signs and likewise be ready for them after you're done with your treatment. Does that make sense? Because I understand what you're saying. You don't want to send them off with a tooth that's out of the mouth. But at the same time, if you start putting nitrous oxide or anything else, you could really push that child into a significant closed head response that would be very damaging. All right. Pulpal management. So now we're going to kind of get into the meat and bones of the presentation, which is how I am going to manage the pulp tissue. And probably what I will do is, at about an hour and a half, I will stop and we will take a break. I will also, you can ask any questions, but we'll take a 20-minute break. So probably in about 30 to 35 minutes, we're going to take a 20-minute break. Okay, so one of the real important things to understand when we are talking about tooth with immature apex is that when we talk about regeneration or revascularization, we are relying on the body's ability to utilize stem cells to regenerate pulp tissue. And I'm putting that in quotations, and we'll talk about why in just a little bit. These are examples of different types of stem cells. Dental follicle stem cells from the apical papilla, pulp stem cells from human exfoliated teeth, periodontal ligament stem cells, and dental implant stem cells. We are really going to focus on the dental apical papilla stem cells and the dental pulp stem cells, but more so the apical papilla, because that is really what we're dealing with when we're talking about the open apex tooth. So these are three examples of different ways that we can regenerate or revascularize a tooth. So in the far left, this is the most common, which is we have apical stem cells, and we use regenerative endodontics, which is bioactive materials, to actually give a scaffold that is the blood clot inside an otherwise necrotic pulp. The middle one is actually taking postnatal stem cells and injecting it into the pulp. And finally, transplantation of postnatal stem cells in sheets, essentially like Surgicel, the kind of sheets that you would use. That actually would be sheets of stem cells that you would place into the pulp. For the purposes of this discussion today, and really in my experience, I've only worked on this on the far left. A lot of this stuff that's on these two on the right are in vitro or animal study type situations, but we do regenerative endodontics. But if I revascularize a tooth, is that in fact pulp tissue? So this image here is showing a necrotic empty pulp and apical stem cells. We're going to go through our procedure, but essentially what we do is we elicit bleeding. We put in a seal, it can be MTA or other materials, and then these stem cells actually migrate into the blood clot and generate pulp-like cells. or in some cases in the literature, you'll see them described as pulpoid cells. This study by Peng in 2007 actually showed that the apical and middle and upper third of the canal was not exactly the same, and that these layers of cells differentiated based on the anatomic features. There is still some debate whether this is indeed true pulp tissue or pulp-like tissue that is histologically examined. So case 1. First, I'd like to get into a case and kind of talk about this. So we have an 8-year-old female who tripped while walking on the sidewalk. Number 9 is extruded 10 to 15 millimeters, was held in by minimal soft tissue. Patient reported to the ED where 9 had to be extracted because it was essentially out, irrigated the socket to remove the blood clot, and then placed back in. Splint presented from primary canine to primary canine, and there was a suture splint. Now, a suture splint means that I go, let's see if I have a picture. Suture splint means I suture from here over to the lingual, and then over to the lingual, and then I put a composite button, and so the suture acts like a sling, keeping the tooth in place. So a suture splint was used as well. Tooth number 8 partially erupted with about half the crown visible. Clinically consistent with normal eruption pattern. 9 is more erupted than 8 with 70% crown visible. Pulp vitality testing. Now, first off, we should say pulp vitality testing is not going to be of a lot of benefit in this case because it's an open apex. Open apex can have dramatically varied pulp responses. So the one reason we do it is also to help us understand how reliable is this child. Do they say yes to everything? Now, mistake here in this particular write-up, and this is an actual write-up, actual case from a resident, is that they did not note any control teeth being tested. So ideally, to assess the child's reliability, we would like to test control teeth. So maybe 24, 25, or a canine, teeth that are away from the site of injury. Since no signs of infection at this point, continue to monitor number 9. And very important, we always want to note the behavior of the patient because that's going to help us as we treatment plan them down the line. So now we have a patient who was, this same patient was lost to follow-up for 8 months, came back in on clindamycin, followed by amoxicillin for lip swelling and an abscess. This is what the tooth looks like now. A pulpectomy was completed at this visit. So they accessed the canal, they established a working length, determining via radiograph, because an apex locator is going to be highly unreliable in this type of a case. Our diagnosis is periapical radiolucency on number 9 and replacement resorption on the distal of number 9 root. Dentinal bridge forming at the apex of number 9. So this is what we call apexification. So what we did here was instrument the canal with a broach, remove the pulp, and irrigated with sodium hypochlorite, dried the canal, and placed calcium hydroxide in the canal. So just a word about, I talked about that we use magnification, we use the radiograph. So typically what you'll do is you'll take a radiograph measurement. Here at Cincinnati Children's, we use Axiom, but all platforms should have a ruler feature. Take a radiograph measurement, use an objective measurement that can be compared to clinical exam. So for example, width of the incisal edge. Here, it's 8.5 millimeters. Let's say when I compare it, it's actually 10 millimeters clinically. then I know what the magnification factor is, and I get a better idea of my working length. So 15 months, so this one was 9 months, or so basically 9 months. Then they came back at 15 months. More dental bridge forming, still immature. Our vitality testing is still really not there. Since no signs of infection at this point and more dentin has been deposited, we will continue to monitor number 9 and that it may darken. So now we bring the patient back 4 months later. 4 months later, patient is asymptomatic. Patient is not, the tooth number 9 is not mobile, but it is slightly more gray than 8. We did a perio probing to make sure there is no perio defect. Patient is nervous, and endo-ice may not be a reliable test. So that since tooth has dental bridge, root may not grow in length, which it likely will not. So we're going to continue to monitor this tooth. 22-month follow-up. Number 9 is currently asymptomatic. Number 9, we got back in there, we accessed the canal, we removed the temporary restoration because we did not obturate here. And so what we did is we used, and we're going to talk about biodentine, and then we used a gutta-percha point over it. And this is what the final fill looks like. So an important thing about keeping this tooth, aside from the aesthetics of it, is that keeping this tooth maintains my horizontal bone level. And that is going to help me when this patient is older and I'm going to go in for possibly an implant consult. Having that bone level means there's a good chance I won't require a bone graft. If I remove that tooth, what happens is the bone will actually shrink height-wise and width-wise. And so before I do an implant, I'm probably going to have a bone graft, alveolar bone graft, prior to the implant. All right, case 2. 6-year-old female with a history of jet ski accident in Hilton Head, South Carolina. Chin hit the handlebar of the jet ski. Avulsion of number 9, subluxation of number 8. The mother of the child showed a picture of the injury with gingival bleeding. Tooth D, as in dog, was avulsed, and an uncomplicated fracture of number 25. Mother reports they put number 9 in milk right away, and the ED reimplanted the tooth around 1 hour post-trauma. Patient sent to the local surgeon, oral surgeon, who placed a splint from C to H. This is the 1-month follow-up that they've now come to our practice. So one word about the wire type. Remember that ideally we want a passive splint. So fishing line is a good passive splint, or a light stainless steel arch wire. So like an 016 stainless steel or an 018 stainless steel. I would not use nickel titanium, so do not use a night tie wire, because the night tie wire is active. So if I put it on the tooth, it's actually going to want to go back to its original form and will start moving the tooth. So if you are just splinting for passive splint, use either a fishing line or a low-grade stainless steel arch wire. So that's our 1-month follow-up. 3-month follow-up, palpation is negative, thermal cold. 8 has a response, 9 has a delayed response. Removal of that splint. Discuss with mom that 9 is still highly mobile and patient needs to continue to not bite into anything for at least another week. Discuss signs and symptoms of infection. Told mother that 9 could survive, but it could have a root resorption or the pulp could become necrotic. If we get a necrosis or pathology, we will do a root canal. Let me see. Yeah. Now, a real challenge here is this part where I said Patient needs to continue to not bite into anything for at least another week. What we know from the literature of traumatic dental injuries is that kids who injure their teeth, 60% of those kids will injure their tooth again. So this is a 6-year-old. I mean, she's going to forget not to bite into something. She's going to be playing at school. So you really have to prepare the parents that this is a significant risk. I know plenty of dentists who would keep the splint on until there's more root development, and that is a potential option. Good. All right, case 3. Patient presents with a concern about fracture number 9. Mother concerns that explains the patient had trauma over a year ago. Tooth was abscessed several times since then. They're not in pain today. So when we look in there, we do see a periapical radiolucency. Tooth number 9 is negative to the cold and is palpation positive. Excuse me. Ooh. So the question is, when we have palpation positive, what does that mean? Palpation positive means that as I'm palpating, I'm actually feeling the area of bony destruction. So that's suggestive that the infection has spread into the periradicular area. A child who is positive on a percussion typically means that that inflammation has spread to the PDL, and now there is PDL edema that is putting that tooth in kind of a micro hyperocclusion. So that's why they're positive to percussion or positive to palpation. So findings charted. We discussed the risk and benefits. We decided to place calcium hydroxide. Got nervous about treatment, but calmed down again after the resident spoke to him. So 1 month later, removed the cavit after the pulpectomy. Irrigated with sodium hypochlorite. It's important to remember that sodium hypochlorite will not damage a vital pulp. So if I have an open apex tooth, I have a good rubber dam isolation, you're never going to be wrong irrigating with sodium hypochlorite. So people ask, well, what about an open apex? So what about like this? As long as you place the syringe at the opening, you are not engaging into the canal, you can very gently irrigate with sodium hypochlorite. Sometimes what I'll do is I'll fill the chamber with sodium hypochlorite, then take a paper point and wick it down into the canal. So rinse with sodium hypochlorite with EDTA, and then placed a size 70 gutta percha point and glossonomer over there, cotton pellet, and then it'll go for final restoration. And this is the 6-week post-initial visit, showing good obturation and a nice strip crown. So are there any other options? So there is lesion sterilization and repair. So this is something that's really coming out more so in pediatric pulp therapy, but it's the same principle as revascularization or regeneration. Essentially what you do, it is a non-instrumentation endodontic therapy developed in Japan, and the operating principle is if the lesion is sterilized or disinfected, tissue repair can occur from those pulp and apical stem cells. So irreversible pulpitis or necrosis, preventing tooth damage to a tooth bud because you don't want to do a pulpectomy on a primary tooth, preventing extraction, so using it as a space maintainer, preventing damage from sodium hypochlorite accidents, and it is less time needed than completing a pulpectomy. So there's a great webinar on the American Board of Pediatric Dentists College of Diplomates, and really where this has been pioneered is out of Wisconsin. So Dr. Hodgson, who's out of Wisconsin, Dr. Barbeau, they're my personal sources if I ever have any questions on how to do lesion sterilization. So infected primary molar, here's an example, the initial 3 months post-op and then 11 months post-op. And that's fairly impressive healing that's occurring in that area. So what this is we're using a triple antibiotic, and that is intended to have a very broad spectrum. Metronidazole, ciprofloxacin, and clindamycin. Now you can use iodoform, which is a radio-opaquer with that. Originally, minocycline was used instead of clindamycin, but the problem is minocycline contributed to discoloration of the crown. So the procedure is 30% metronidazole, 30% ciprofloxacin, and 30% clindamycin with 10% iodoform, 300 milligrams of polyethylene glycol, as well as macrogol. And those are actually the vehicle, almost like gelatin, that help carry and increase the lifespan of the antibiotic. Now, what we have here at the hospital is we have this mix on top pre-packaged. And then we have a separate syringe with the polyethylene glycol and propylene glycol. And then we mix the two together to give us kind of that slurry that we're going to put in the tooth. So you must use a rubber dam. Tooth is open, pulp chamber is entered. Remember that we are only doing a pulpotomy. We're only removing radicular pulp. Tissue removed from coronal portion. Orifice is scrubbed with 35% phosphoric acid, triple antibiotic powder and liquid, and then seal with GI cement. And typically we are restoring with a stainless steel crown. So again, that's what we have here. This is an example of where we have the meds and then the vehicle, and that is actually mixed into a slurry at the time of the appointment. So this is what you get: necrotic, placement of it, GI, and then eventually we're going to place a crown over it. So the parent has to be willing to accept the risks that it won't work, and the tooth may need to be extracted. Excuse me. You may have to accept, how am I going to bill for this? So if I extract the tooth within a month, I'm going to not charge. If the tooth lasts a year and I have to take it out, I'm still going to charge for the extraction. So I think that's individual, practice by practice. Other procedure protocols, oral antibiotics if they need it. They have a vestibular swelling, and you must have a pre-operative radiograph. So this is actually the formula from the Wisconsin folks. This is what they use. So if you're interested, please feel free to reach out to me. But again, like I said, the Wisconsin folks are really the authority on this procedure. No set follow-up. I mean, I would typically do 1 month, 6 month, or 1 month, 3 months, 6 month to make sure that things are healing. Contraindications, any antibiotic allergy, and any evidence of actual root resorption. So you can see here, while there's furcal resorption, there's no radicular resorption. Maybe a little bit here, but not significant amount of radicular resorption. So this is a very successful process. And and it is something to consider in your bag of tricks. So this is an example of, again, significant radiolucency and then healing following placement of the antibiotic. Again, here's an example. Good. So I think what I'm going to do, Phil, eye in the sky, I think I'm going to go ahead and take a break right now. And let's take a 20-minute break, but I will be looking at the chat box if there are questions. All right. Excuse me. All right, everyone. Hope everyone had a nice little break. I went and got myself a Starbucks Frappuccino. Starbucks, the sponsor of this. No, I'm just kidding. And so now we're gonna continue on. And I haven't seen any other questions or comments come through. So hopefully I'm being clear and I'm making sense. And if I'm not, please let me know. So what we're going to talk now is we're going to talk about restorative management, but I have lumped into there all the different endodontic materials that we will use as well. It used to be that we only really used calcium hydroxide for everything. And that was our big apexogenesis medication. But times have changed, and we definitely have a lot more medications at our disposal. So we're going to go through those materials and talk a little bit about that too. I did have a couple of notes of things that I wanted to make sure I commented. And so I'm going to briefly go back. Well, I'm not going to go back, but when we are working on an immature tooth and we are going to do revascularization, it is important that we use a local anesthetic without vasoconstrictor. Because, you know, what happens is if you use a vasoconstrictor and then you're trying, pardon me, you're trying to elicit bleeding, if you've used a vasoconstrictor, you're not going to be able to do that. So ideally, you are using a local anesthetic that has no vasoconstrictor for any regenerative endodontic procedures. Okay. With that, we're going to jump into our restorative management, which is really looking at what are called bioactive restoratives. So bioactive, the definition is something that remineralizes the tooth, strengthens the tooth, and uses fluoride release to actually improve the surrounding area of the restoration. It can form an apatite-like material on its surface when it is immersed in body fluid or simulated body fluid over time. So we're going to come back to that, but the formation of hydroxyapatite is key when we talk about a good biorestorative. Regenerates live tissue to promote vitality in the tooth. So that's where a lot of our endodontic materials are going to come. Note that our bioactivity, what that means is, does this have any effect on or interaction with living tissue? So a big advantage of MTA, mineral trioxide aggregate, is that it has a very high degree of bioactivity and biocompatibility compared to some other materials that have been used historically. So this is actually the formal definition. It provides, so it has to be able to form apatite by 28 days in simulated body fluid. That is the technical definition of bioactive material. Traditional formulations of glass ionomers, resin-modified glass ionomers, and fluoride-releasing compounds are not bioactive because they do not demonstrate formation of apatite. They are biointeractive, so there is some interaction, but they're not actually creating the apatite. Remember, that is the key if any material advertises itself as bioactive. So really that definition differentiates all the fluoride-releasing glass ionomers from our two big bioactives, calcium silicate and calcium aluminate biomaterials. So there was a study done and they tested all of these materials. Biodentine, which we'll talk about Theracal, Dical, which is very commonly used, MTA, and we're going to talk about all the different formulations of MTA, and Limelight, which is again a glass ionomer that contains hydroxyapatite, but is not stimulating apatite formation. So what we found, Gandolfini et al., the highest rate of calcium release and the fastest formation of apatite represent epigenetic signals for pulp cells and may explain the role and function of calcium silicate biomaterials as scaffolds to induce new reparative pulp tissue or dentinal bridge. So calcium silicate, when they say epigenetic, what that means is that calcium silicate actually activates certain components of the genetic code that allows for migration and induction of new regenerative cells, not only pulp cells, but in this case, dentinal bridge cells. Remember that for many years, the thought was, oh, dical releases calcium hydroxide, and that's what causes the dentinal bridge. More recent studies have demonstrated that it is actually the agitation with the handpiece that causes the formation of reparative dentin, which is what that dentinal bridge we see post-dical is more commonly related to. So bioactive materials must fall into one of these two compositional classes, calcium silicates and calcium aluminates. So they typically set with an acid-base chemical reaction and produce an alkaline pH after setting. And that's important because alkaline pHs are antibacterial. Remember that when we talk about bacteria that promote dental disease, these bacteria are considered acidogenic, meaning they produce acid, and acid uric, ACIDURIC. Acid uric means they can survive an acid. Alkaline materials such as calcium hydroxide and MTA have a have an antibacterial effect because the pH is so high. So remember that when pH is low, and remember our critical pH is 5.5, and that is the point at which the enamel remin demin arrow favors demineralization. Once we get back up above 5.5, then it favors remineralization. So what these materials do, which is shows here, is fluoroapatite materials have a pH closer to 7. And here, carbonated apatite is also closer to 7, whereas partially dissolved apatite is down around the 5 pH level. Now, what's important also to note is that hydroxyapatite starts dissolving at a pH of 5.5. That's called the critical pH. Every material has its own critical pH. Fluoroapatite, so that's when fluoride is incorporated into the apatite lattice, actually has a critical pH that is lower than hydroxyapatite. So fluoroapatite has a critical pH of 4.5. What this means from a restorative perspective is that we get less demineralization of our supporting enamel and that is supporting the restorative material when we have fluoroapatite. So these materials that release fluoride into the ambient salivary pellicle and biofilm can actually increase the fluoride concentration, which then increases the formation of fluoroapatite. So this is some examples of our bioactives. The bioactives work in one of three ways. They either cause remineralization, so it's our glass ionomer derivatives. They deposit hydroxyapatite, so this is ceramere cement, or they can do pulp regeneration, which is our MTA and biodentine. So I think this table is useful to showing you that really, as we get down towards our pulp regenerating materials, that is the peak of bioactive interactions. So remineralization in the 1970s, there was glass ionomer cements such as Riva that had a true chemical bond, and there was an ion exchange occurring between the enamel and the dentin, resulting in an ion-enriched layer where the tooth and the GI cement met. We have GIomers, which is a glass ionomer plus a composite resin. So they have fluoride release into the ambient area. This fluoride release is often noted as being rechargeable. So what that means is that if I brush my teeth, the fluoride level goes up and it'll stay typically 3 to 5 days, and then it goes back down. But I brush my teeth again, it goes back up, and then it goes back down. So fluoride can be activated through the toothpaste use with bioactive materials. What's important to note is if we use glass ionomer with our composites, for this effect to be optimized, we would need to do what's called an open sandwich technique. Open sandwich technique means the resin sits on the glass ionomer, but the glass ionomer at the base is exposed to the oral environment. And that oral environment is what's drawing the fluoride from the rechargeable glass ionomer or GIomer. The GIomers also have the physical properties of composite resins. They are comparable to hybrid resin composites in regards to physical performance and properties. So it's not quite, but it is akin to compomers, which have also been utilized, and in fact for pediatric teeth, compomers are noted to have the best survivability of intracoronal restoratives when compared to amalgam and composite resin and resin modified glass ionomers. Compomers and GIomers are really good in primary teeth. So this is what I was talking about in terms of the critical pH. Here, the critical pH is 5.5, and so we get demineralization. If we get more fluoroapatite, which could be from our glass ionomers, we get a lowered critical pH of 4.5. So what hydroxyapatite has to do with teeth is that is what gives us the lattice that is the base unit structure of a tooth. So this just shows you as an example, a resin modified glass ionomer, even if it was only down here and this was composite on top, would be releasing fluoride, and you would get increasing concentrations of fluoroapatite in the area. So hydroxyapatite deposition, this is what defines a true bioactive material, often non-resin based, and a post-set alkaline pH. So biodentine, and this is a disadvantage for us when we speak to a large crowd and we're not there in person, is I would like to ask how many of you have ever used biodentine or actually are aware of it. And biodentine is a bioactive restorative that remineralizes, deposits hydroxyapatite, and regenerates live tissue. It really does represent the next frontier in restoratives. And when we start talking about our endodontic materials as well, it's a very highly recommended restorative material. It's a powder component of tricalcium silicate, dicalcium silicate, calcium carbonate, and oxide fillers. So the zirconium oxide is makes your appearance opaque. Compared to MTA, it is easier to handle, has a higher viscosity, and a shorter setting time. So where am I using biodentine? I'm using it when I'm doing my direct or my indirect pulp caps. This is highly advantageous. Good color stability, which is another difference with MTA. MTA has somewhat poor color stability, and so I would consider that MTA is not a great anterior pulp capping agent because you can get discoloration of the tooth. So a question that's come through is, what are the thoughts on using Vitapex by PulpDent for pulpectomy treatment? So Vitapex is like Diapex. It's iodoform calcium hydroxide. The only problem that I see with that is that it's yellow. And so if you are talking about an aesthetically sensitive area, that Vitapex can sometimes cause staining. But if you're just using a small amount that's actually intimately sitting with the pulp, then it should not be an issue. Okay. So biodentine is something that can also be used for pulp capping, both direct and indirect. And I'll tell you, it's really interesting in residency. So I've been teaching now for about 15 years, and I've been here at Cincinnati for about 7. And I will tell you, from when I started in academics to now, the frequency of pulpotomy and indirect pulp cap has completely changed. So I will have residents who may graduate doing 10, 20, 40 pulpotomies, whereas my residents maybe a decade ago would have graduated easily doing 200, 300 pulpotomies. But I am also getting residents graduating with doing 300, 400 indirect pulp caps versus 10 years ago, where it was much lower. Now, one thing I will say is when you are actually documenting an indirect pulp cap, what I've heard some people suggest is that if I do a crown and use glass ionomer cement, put it over, that's an indirect pulp cap. My feeling is to charge it as an indirect pulp cap, you've got to demonstrate that you actually removed infected dentin, which is the soft stuff, and what you left was affected dentin, which is hard. So to me, that goes into how you document your use of, for example, just because you use biodentine doesn't mean that it's an indirect pulp cap. You've got to be very specific in your documentation why you are considering this an indirect pulp cap. So this is an example here of some biodentine that is used over the obturation of the tooth. So this is MTA that's placed, and then they place biodentine over it, and they restored the tooth. Another big material, and this is one that we are using more and more, particularly with our immature apex therapies, is endosequence. Endosequence is a pre-mixed root canal sealer which has bioceramics. So it's different than gutta percha. It is more biocompatible than gutta percha. And it actually can help, it helps get a better seal because it can draw on the moisture in the surrounding area. So we are using endosequence more and more often for our CVEK pulpotomies, the partial pulpotomies. We are using endosequence. Again, another big advantage, very high pH. And that high pH is antibacterial. So it can come, you can either use it as a syringe, and if you do a CVEK pulpotomy, damp cotton pellet, remove the damp cotton pellet, place your endosequence directly over, then you can also use that as well. AH26 is a root canal sealer that we are using, which is a resin-based non-acrylic eugenol-free sealer. So we are using, again, it's radio opaque, set time of 12 to 48 hours. And so we are using this with our gutta percha to help with sealing for a full obturation. So mineral trioxide aggregate. This is really, I feel in the general dentistry world, in the pediatric dentistry world, this has become a huge bonus. So it used to be that MTA was made by ProRoot, Tulsa, and it was patented. Well, when the patent ran out, you started seeing all these other brands of MTA come out, and for years, the biggest downside of MTA was the cost. It was $300 for a 5-gram packet. So the cost has come down. We still do have issues with discoloration and MTA. So in the anterior, you've really got to be careful where you're using it and how you're using it, and if it is, again, above the CEJ. If it's sitting above the CEJ, high likelihood you're going to get some discoloration. And it's important to distinguish that goes for not only gray MTA, but white MTA as well. White MTA will cause discoloration as well as gray. So really the next iteration, New Smile has this Neo MTA putty, which comes right out. You just squeeze it out and you place that directly in. This is for posterior teeth primarily that we're thinking of, posterior pulpotomies on both primary and permanent teeth. Again, it can be used in the anterior. The biggest problem is there is the risk of discoloration. So this is treatment of open apex teeth using white mineral trioxide aggregate. So you'll see kind of where it's sitting. This is actually the MTA is sitting down here. Then it's obturated with gutta percha, and then there is a resin. High alkalinity, final set time of 3 hours. So if we are doing this, if we are placing MTA, because MTA takes 3 hours to set, if I have MTA sitting like this and I push down to condense on MTA, what happens is the MTA spreads because it's not set. So what I have to do is over my MTA, I put a thin layer of glass ionomer. Vitribond is fine. And so that way I can put my resin and I can condense it against the glass ionomer and not condensing it against an unset MTA. So, for years we've looked at it as Portland cement. It's our sidewalks. I'm sorry, I'm coughing. I'm not COVID infected, don't worry. The current standard for care of conservative reparative pulpotherapy really is MTA. So if we look at all the potential pulp medicaments, and this is like for posterior teeth, formicresol, ferric sulfate, some people use sodium hypochlorite. MTA really is emerging now as the real gold standard for pulpal treatment of pulpotomies or immature teeth that are being managed. Again, if we're talking about immature anteriors, as long as we place it below the CEJ, as long as we prepare the family that there may be discoloration, then it's still a wonderful material for that indication. So question, do you or the residents have a preference between the Neo-MTA water powder mix versus the Neo-Putty regarding workability, success, or other factors? I'll be honest, we have really just started recently using the Neo-Putty, and the Neo-Putty is extremely easy to handle compared to the Neo-MTA water powder mix. It's so much easier to get a nice thick mix versus the kind of slurry. I feel like I mix a lot to get the Neo-MTA water powder up to a good ratio. So I personally, from our program here at Cincinnati, I would not be surprised if in the near future that Neo-Putty really becomes our standard of care. Now, we are still teaching residents formicresol, ferric sulfate, and all of these, but that's more so to prepare them when they go into practice. But I would say that within the next 5 years, if not already, the MTA pulpotomies on primary teeth and even permanent teeth will become a standard of care. I really do feel that. So this is from the AAPD best practice guideline, basically saying that MTA is used for pulpotomies with a high rate of success and that MTA performs equal to or better than formicresol or ferric sulfate. Now, there's something else that here, it says calcium hydroxide has been used, but with less long-term success. So here's a point I want to make. If you get into a situation, permanent anterior tooth, primary tooth, you're doing open apex treatment, you are not sure what to put in there, you are never going to go wrong with calcium hydroxide. It is a wonderful material. It is a workhorse. It can cause some discoloration, but less discoloration than MTA. And again, if you can place it below the CEJ, it's going to work out just fine. So if you're ever in a situation where you're like, okay, I don't know what to do right now, calcium hydroxide, that is your safe bet. That is a material that always works well and can always be replaced later on with treatment. So sometimes we have disadvantages with MTA, and those disadvantages are really the discoloration and that we need to be able to put glass ionomer over to ensure that it has an adequate set time. But MTA, as with calcium hydroxide and the endo sequence, these are directly contacting pulp tissue. The Vitribond is not. The Limelight is not. Glass ionomer and resin are not directly contacting the pulp. So types of MTA, Jeff asked a question about this. So this is the Neo MTA where you are actually mixing the powder liquid. I think that's a great option. I particularly like that option if I'm doing an indirect pulp cap. So if I'm doing that on an anterior tooth that has a uncomplicated fracture, so fracture with no pulp exposure, I think that's another potential good alternative. ProRoot MTA, that's really the standard that most of us kind of grew up with dentally. And then Angelus is a form that is, again, a powder liquid. And I mean, we kind of use it synonymously with our ProRoot. Here at Cincinnati, we have the Neo MTA, the Angelus, and the ProRoot. because we've gotten them at different times. Right now, I've tasked one of my faculty who's kind of over my materials to kind of cut our materials down. And his recommendation is really that we go with the Neo MTA putty. So that's what I anticipate once we get all the faculty input. That's what I anticipate we're going to go to. There was one other thing I wanted to talk about here. Okay, I'll come back to it. So bioglass is the first formulation of an artificial material that was found to chemically bond to bone. So it's a very historically biocompatible material and is used in dental restorative materials, but you can also order bioglass countertops and bioglass furniture. Ceramere is a calcium aluminate cement. Remember that calcium aluminate is one of our bioactive materials. So it can occlude marginal gaps because it actually helps in the formation of either hydroxyapatite or fluoroapatite in the marginal gaps of the restoration. So that stimulation leads to regeneration of dentin, pulp, microvasculature, and bone. So it is something that where we're using the cement, for years we talked about amalgam, and amalgam had self-sealing corrosion, which actually helped prevent further decay. Ceramere takes this to the next level. Ceramere is now a cement that can stimulate hydroxyapatite and fluoroapatite levels to actually seal up your restoration. So, a couple of questions here. What is your instrument for delivery of these mixable MTAs to the tooth? Fantastic question. Let me go back here. So typically, when we mix the MTA and it looks like this, what I like to do is I have a dedicated amalgam carrier that is just for MTA. And I will actually take the MTA in the amalgam carrier and I do the same thing for calcium hydroxide. I take the calcium hydroxide powder for like a CVEK into the amalgam carrier and I push it directly, so I'm actively contacting that tissue. So I tend to use an amalgam carrier. Now, ProRoot actually has a amalgam carrier that is plastic, and that plastic carrier is meant only for MTA. So if you reach out to any of these MTA companies, they will actually have a carrier that you can place that. That's what I like. If I place it with a syringe, like the Neo Putty or something, then I will use a condenser, just like I would with an amalgam, and I would adapt it. But the other thing that really works well is you take a damp cotton pellet and you adapt the MTA to the preparation with the damp pellet, and then you put your Vitrabond over that MTA. Another question. When doing caries removal in a primary tooth and there is a pinpoint pulp exposure, why is it that a direct pulp cap with DICAL is contraindicated and instead full pulpotomy is needed? So the rationale is that if you have a caries exposure, that the caries has already infiltrated the pulp. I think the other piece really is the behavior piece, that if the child comes in pain, comes in with a swelling, comes in with an abscess, then the behavior is going to be worse. And overall, the prognosis of a direct pulp cap on primary molars is not as good as a direct pulp cap on a permanent tooth. I will say, I'll give you a little self-confession here. This is a safe space, especially since I'm speaking to a camera. When I was in dental school, so I had no cavities through childhood. Then I got to dental school and I got my first cavity. I also gained like 20 pounds. It was ridiculous. So what did I do? I had a friend in dental school and I said, hey, you want to do my filling? And he was like, that would be great. And it was on the radiograph, it was a very small interproximal, might have even been a board lesion. Next thing I know, and my friend, he's still a good friend of mine, he goes in and he's doing it and he goes, uh-oh. And I'm like, what? He's like, oh, you got high pulp horns. And I'm like, I didn't notice that on the radiograph, but he had a pulp exposure. He had a pulp exposure. And so he said, well, what should we do? And I said, you know, I've had no symptoms on this tooth. Go ahead and do a direct pulp cap on the tooth. So he did a direct pulp cap, did a composite over it. Fast forward about 2 years, and now I'm in the Air Force, and I'm here at Wright-Patterson Air Force Base in Dayton, Ohio, and I'm doing an AGD, and suddenly I wake up and my tooth is throbbing. And turns out, yeah, pulp was necrotic. And I fortunately had an endodontist in my residency, AGD. He did my root canal on that tooth. And he was saying, you know, pulp caps keep me in business. So you've really got to be careful with direct pulp caps because you've really got to prepare the family and the patient for what could occur. So to answer the question, long story short, I think a lot of it has to do with the evidence that primary teeth do not respond well to direct pulp caps. 2, there's caries exposure, so there's a caries contaminated pulp. And 3, the behavior of the child if they come back in pain. So those are the reasons why we typically don't do direct pulp caps. So a lot of people will now do an indirect pulp cap. If there is no symptoms, they'll leave some of that affected dentin and put some Vitrabond or put some biodentine over it and then seal the tooth. Hopefully that answers the question so far. If I'm not being clear, please write back that you'd like me to explain that again. So we were talking about ceramere and how ceramere actually occludes marginal gaps because it helps form apatite. That's amazing. So when you look here, this is actually showing ceramere as potentially, this is calcium aluminate, doing potential for bone repair in areas affecting osteoblastic cells. So, I mean, we really don't know where this is going. I think there is a huge frontier out there with these bioactive materials and in kind of triggering the body to its own healing response. Biosem. So biosem is used on a lot of, for zirconia crowns in primary teeth. Stimulates the formation of mineral calcium and fluoride ions and is similar to that in chemical composition. So biosem is hydrophilic and it allows you to cement with without really good isolation because it gives you the formation of hydroxyapatite and it does form a washout that is resistant and that gives you a seal that is resistant to washout. So no HEMA, no bisphenol A, no bis-GMA, or no BPA, bisphenol A. So this is an example of where the biosem actually is forming hydroxyapatite that is engaging the dentinal tubules. So what that shows is that the New Smile Biosem for a stainless steel crown had a much higher force required for removal than Ketac-Sem. Same thing when we're talking about zirconia crowns, it was much higher than the Ketac-Sem. So what all of this is doing is these bioactive materials are triggering these phosphatases that actually help produce and release calcium, phosphate, and fluoride from the environment. So modified calcium silicate is known as Theracal, and that is something that, again, is also used either as partial pulpotomy or used for indirect pulp caps. So in this case, biodentine had complete dentinal bridge formation in all teeth. 56% for the ProRoot MTA, 11% for Theracal. Normal pulp organization, 66% in biodentine, 33% in ProRoot, and 11% in Theracal. So the carrot Theracal does not work as effectively as the biodentine. So if I was going to invest in a bioactive material, I would really consider investing in biodentine. And I'm not getting paid by biodentine, no disclosures required, but I do think it's a really effective material. So now we want to talk a little bit, are there any other questions about kind of this restorative management? So what I'd like to do is I'm going to talk a little bit about the behavior, and then I'm actually going to go backwards and I'm go to the pulp exposure section, because now that we've gone through all this information, I think if I go back through that, you're actually going to get that a little different than we did the first time. So I'm going to go through some behavior management, and then I'm going to go back to the pulp exposures. So how am I treating this child? This is really critical. Do you have operating room access? Do you have an anesthesiologist that actually comes to your office to do general anesthesia? If you do, how many times are you willing and able to do this? If a patient is patently uncooperative, how many times can you, and you have to go to GA or sedation for every appointment, how often are you going to do that? And at what point are you going to say, well, he's going to have to cooperate in the chair for this? Because you do set those expectations with the parents. Procedural sedation, is that even an option? Do you use nitrous oxide in your office? Is nitrous oxide something that'll work? You'll find that the kids who come in on trauma very often are already hyperventilating. They're already crying, and sometimes they're not even going to tolerate anything like nitrous oxide. Now, if you go to a hospital ED, and I know some practitioners who will take the patient, go to the ED, and will actually sedate the child with the ED. So the ED will use ketamine or something. That's different, but that requires more effort on your part, whether you're going to do that or not. So I think that kind of comes down to what you're willing to do. So what about orthodontics and trauma? And this question gets asked so many times. So I have a luxated tooth, an intruded tooth. When can I start putting forces on it right away? I have a kid in ortho who has a luxated tooth like this. How soon can I resume ortho treatment? The standard recommendation is that it is 6 months post-trauma when you can safely initiate ortho. Sorry, that should say ortho, not endo. But that is really based on scant and unsubstantiated literature. the thought is that you are acting inflammatory pathways, including osteoclastic activity, by putting force on the periapical regions of the teeth. So what could happen is you could use ortho, but you have to use light intermittent forces versus light or moderate continuous forces. So that comes down to something that you have to then consider, because orthodontist is going to say, hey, I can move this tooth right away. If it's an open apex tooth, I'm more prone to let the orthodontist move the teeth than I am if it is a closed apex tooth. Because what's happening at the apex in a closed and open apex is totally different. Now, some situations may benefit from immediate ortho. So let's take this scenario right here where we have teeth 9 and 10 that are luxated palatally. But it looks like these other teeth, 6, 7, and 11, or 6, 7, 8, and 11 are in good position. I would tie these in, and I would see if I could reposition this tooth and then lightly tie it in to the wire. And if I could do that the same day, I think I would. We know that with closed apices, significant luxation, laterally, intrusive, extrusive, increases the chance that there's going to be endo that's required. So I think as long as the parent is really understanding of that, I would go ahead and I would reposition that. So I want to go back to my pulpotomy, or my initial thing. Hope I'm not giving anyone seizures by doing this. Sorry. Okay. So now with everything that we've talked about in terms of the restoratives, what we know is that if we are going to pulp cap this exposure, so I'm going to pulp cap that and then I'm going to restore over it, we're either doing something like DICAL and Vitrabond. Okay. We can also do, which I would prefer, is biodentine and then restore over it. Now there's some questions about, hey, when can I actually restore this? And what we don't want to do is we don't want to do a lot of vibration that further injures the tooth. So in this case, with open contacts, I would personally take an adult strip crown form, fill it with composite, and just basically put my biodentine down right there, and then put my strip crown form over it, seal that all in, and then revise that at a later date. You could go in and you could freehand this. I just don't want to do a lot of polishing. This is an interim restoration. The other thing a lot of people will do that I think is a fantastic idea is you take a heavy body polyvinyl siloxane or polyvinyl putty, and you make a matrix. So basically you push something along the back of all of these teeth, and then that gives you a matrix, and you fill the composite against that matrix and then remove that. But this is, like we talked about, this is going to be really traumatic for this kid to go back to school looking like that. So my preferred treatment here, biodentine, composite strip crown on top. I think totally acceptable. DICAL, Vitrabond, strip crown on top. Acceptable, but maybe a hard sell to the parents, DICAL and Vitrabond. Some people will even go so far as to put DICAL, Vitrabond, and then a flowable Band-Aid over the tooth as well. So same thing here. If I am treating this tooth, So let's just assume, for sake of argument, that this is an open apex tooth. I am going to go do a SVEK. And oh, I know what I wanted to say earlier, and this reminded me of it. So when there is a trauma, when there is a uncomplicated fracture, no pulp exposure, and very often we refer to the pulp as blushing. It's important to understand that when there is a fracture in the tooth, the blood is going to rush to the surface because that's how all our immune factors are getting there to protect. So a kid who has a blushing pulp post an uncomplicated fracture does not surprise me. It does not mean that the pulp is exposed. So what I would do here, I would anesthetize. So let's say it's open apex. I'm going to anesthetize. I'm going to use my regular local with epi. I'm going to go in here with the burr. I'm going to kind of smooth out my prep here. I'm going to take a damp cotton pellet, place the damp pellet on the pulp for about 2 to 3 minutes. And when I remove the pulp, I should get a glossy red pulp that is not actively filling up my chamber. It's just sitting there, but it's red, it's heme, it's active. So at that point, then what I will do is I would personally, as we described, I would take calcium hydroxide in a amalgam carrier, just powder, place it there. Likewise, you can take MTA, same thing, carrier, place it right on the pulp. Again, if you wanted to, you can also consider endosequence or biodentine right over that. And then I'm going to put a barrier, so glass ionomer of Sudden type, and then I'm going to restore over that. Okay? Are there any questions about that technique? So likewise here, when I look at this, this pulp is red, it looks glossy, it is healthy. And that's why I'm not going to remove it all the way past into the canal. I'm just basically removing the chamber, or 2 millimeters of the chamber. So here we will have potentially, if we're doing a revascularization, we are putting endosequence or MTA right there, and then we are restoring over it. And then there's typically Vitribond, and you can see a thin layer distinguishing the restoration and the apical plug. Good. Okay. Let me go back down here. So I'm actually getting very close to the finish of the talk. So I would like to know if there are any other questions. Jeff, is there anything else you can think of that you would like me to cover? If there's any materials anyone would like me to cover, if you put it in the chat box, I'm happy to talk about it. All right. So I'm done with my presentation. I am here for Q&A. So kind of let me know what you guys think. If there's question and answers, I'm happy to stay on, and I'm happy to really talk about anything related to any of the topics that I've talked about. Just as a reminder, please complete the survey. Please complete the survey, and so that we can get that taken care of. Any other case presentation examples for primary or permanent tooth trauma or subluxation? Well, let's see. Yes, I can do that. So do me a favor. What I'm going to do is I'm going to get off here and I'm going to get a presentation I have on luxations. So Phil, I'm going to get off real quick. All right, Phil, you want to bring me back up? And yep, you have my screen there. So what I'm going to do is I'm actually going to talk about, these actually just came out, and this is the International Association of Dental Traumatology, and this is their guidelines for management of traumatic dental injuries, specifically looking at avulsion of permanent teeth. What I will do after this is I will send this article to Jeff, and then he can actually distribute this to everyone as well. So really, the most important thing to note here is that they do talk about, what to do in the immediate accident happens. So what we remember is that our best transport medium is Viaspan, which is an organ transplant medium and is not available anywhere. So we typically say Hank's balanced salt solution, which is it comes in the form of Save-A-Tooth. So I think, and this is something that I've talked to a lot of my pediatric dentists around the area is, I think a great office connection to a local school is to actually supply that school with Save-A-Tooth, because I think the lifespan may be about 6 months or 8 months. Supply your school nurse with Save-A-Tooth so that they have that. If there ever is a trauma, they can actually put the tooth in there and send the kid to your office. I think that's a great way to be preventatively minded, much in the same way that many offices will kind of adopt a local high school sports team or college sports team and make mouth guards for free for that team. So it is something to consider. So they say keep the patient calm. Usually it's keep the parents calm. Find the tooth, pick it up by the crown, and rinse it in milk, saline, or the patient's saliva. So really out of all of those, milk is going to be the most immediately available. So milk is available, rinse it in milk. If they wash it in water, that's okay. Now, a question that comes up very often is, okay, so if I'm at the site of injury, do I put the tooth back in if I'm concerned about the kid's behavior or I'm concerned about the kid's concussion status? So I would say no. Ideally, the kid who it's going in is the kid who is with it, cognitively with it, acting appropriate. I would not put it in a young child. So like a primary tooth, I would not put that in. And the reason for that is that, again, if they pass out, if they faint, then there's a chance that they're going to aspirate or swallow the tooth. Some people have asked about putting it in the vestibule of the child. So they're keeping it in their saliva. Again, you run the risk of the child then playing with it, swallowing it. I mean, there's a lot that could happen there. So I would really not do that. Now, if the kid is okay and it can be replanted, replant the tooth and actually, put a towel, washcloth over it so that they're holding it in place versus just sitting there holding it like that. So I'm going to come back to a couple of these questions after I get through this part here. So then ideally they're coming to the emergency room, which is where they're getting, which is where they're getting the closed head trauma cleared. And then also they can replant the tooth and call you. So I think that's another advantage of going to the ED. I'm not as crazy about them coming straight to you if there is any concern about that closed head trauma. Okay, then. So the main goal is keeping the PDL cells viable. Now, here they talk about an extra alveolar dry time of 30 minutes. That does not include 30 minutes in milk. That means, or in Save-A-Tooth, that means extra alveolar dry. It's in their pocket, it's in a baggie, it's in a washcloth. That's when we would consider the prognosis to significantly start going down. But having said that, and going back to the Kenny article that I referenced in the presentation, I'd still reimplant it if I could. Now, one of the biggest challenges is going to be the patient with a special need, like the patient with autism spectrum disorder, who cannot tolerate, anything in the mouth, has a generalized oral aversion. So in this case, what I would do is really have the discussion about, am I going to replant this? Because if I replant it, I need to splint it, and I need to go under general anesthesia if that's the case. And if that is the case, and it's a closed apex tooth, I would then consider doing the endo in hand. So you do the endo in hand, and I would not obturate with gutta percha. I would remove the pulp, and I would place calcium hydroxide in the pulp, and then I would replant the tooth. And the reason is, if we know it's a poor prognosis, we know it's either going to have replacement resorption or inflammatory resorption. So for that reason, we do not want to put a non-resorbable filling inside the canal. So let's see. We're going to go to our treatment guideline for avulsed permanent teeth with an open apex. So this answers one of the questions here, which is, the question was, so if an ortho patient has trauma, go ahead and go down to an arch wire that is a little more flexible and go ahead and engage brackets. So it's not that the arch wire is flexible, it's that it is lighter. So your comment here is good. So if I have a very heavy gauge rectangular ortho wire, I want to remove that and place a light stainless steel wire that is not going to do a lot of fluctuation. I don't want to put a night tie wire because that's actually going to kind of spring any abnormalities in the eruption pattern. So here they say, stabilize the tooth for 2 weeks using a passive and flexible wire of a diameter up to 0.016. I particularly like using the light stainless steel wire when I have a kid in a transitional dentition. So the kid has C, nothing, E, 9, G, H. When there's all these kinds of questions, then I like using a light passive stainless steel arch wire. They also mention here using a nylon fishing line, 0.3 to 0.25 millimeters. What we also classically say is a 40-pound test fishing line. So that gives enough thickness, but it's not too rigid. So 40-pound test fishing line. Pulp revascularization, we've talked about this. So systemic antibiotics, if I'm going to use antibiotics, I'm really going to try to stick with penicillin if I can. If I can get a kid who will take penicillin 4 times a day, I'll go with that. If it's a very young 6-year-old, maybe I'll go with amoxicillin 3 times a day. Obviously, tetanus status, that they're not lethargic or anything like that. So then they're saying, what if the tooth has been kept in a storage medium and they're coming to you, it's an open apex? Basically, you're going to rinse, clean off the tooth, place it back in, do the same splinting. You're not doing any endo access at this point, but I want you to note that under here it says administer local anesthesia, preferably without vasoconstrictor. Now it also says that over here, but it's really critical when we're talking about anyone with an open apex. That doesn't mean that the vasoconstrictor is contraindicated. You can still use the vasoconstrictor, because what will happen is if you're doing it when you do the regeneration procedure, then you should have no vasoconstrictor. Good. Extra oral time longer than 60 minutes, open apex. This tooth prognosis is going down. But again, we're going to replant it because of normalcy, and if we can help maintain a periodontal bone height so that maybe we don't need a bone graft when the tooth is ultimately extracted. Systemic antibiotics, we talked about. Clinical follow-up, you're going to follow up, and for those of you who do not have not signed up, there is dentaltraumaguide.org, and it's a group that was founded by the late Jens Andreasen from Sweden, and it is outstanding. It basically takes you step by step for any type of injury, any type of apex. dentaltraumaguide.org. We have an institutional membership. All our residents bring that up in the ED when they're down there. We have all our ED fellows, the physicians. We have all of them refer to that so they know when to call us and when we need to be seen immediately. So dentaltraumaguide.org is really outstanding. Good. So another question is, when do you use Limelight? So fantastic question. I use Limelight for indirect pulp caps. Indirect pulp caps, you can use it if you fear there is pulpal blushing. I think any of those situations are good for Limelight, which is, for those of you who don't know, that is calcium hydroxide. So Jeff also mentioned other common injuries in children. Really, the avulsions are the most significant ones. Intrusions, as I mentioned, in some of the cases that we did, intrusions are significant. And so how do I distinguish between orthodontic repositioning and surgical repositioning? If the tooth is intruded more than 6 millimeters, has a closed apex, then I am doing surgical repositioning. That is where we're going to flap the tooth, flap the area, grab the tooth, and reposition it into place because we know that tooth needs endo. Now, open apex tooth, I am always going to give that open apex tooth a chance to re-erupt. Strong likelihood we'll have to do endo, but there's a chance that we won't. Now, if I'm dealing with primary teeth intrusion, so let's say the whole primary central is intruded, I am giving that tooth 6 weeks to actually re-erupt. It's very uncommon that I go in and extract that tooth right away, unless it is so intruded. And I've seen a few of these where you can see the apex through the nose, through the nostril. But open apices, open apices, permanent teeth, I am giving those every chance to regenerate and heal on their own, versus a closed apex where I am being much more aggressive. And the rationale is this: closed apex, full root, any apical resorption reduces the lifespan of that tooth. So rather than waiting, I'm going to be much more aggressive. Open apex, worst case scenario, I'm going to have to remove this tooth. So I'm just going to wait and let that tooth heal and see what I get. If I can hold on to that tooth and I can maintain bone level until the child is available to get implants, that's what I'm going to do. Good. Are there any other questions for me? All right. Jeff, if you don't have anything else, then I think we'll go ahead and sign off, but I will, I'm going to stay on here. So If you guys have questions, please ask those questions. If limelight is calcium hydroxide is an alternative to dical or to Vitribond, it is an alternative to dical. It is not an alternative to Vitribond. Vitribond is a gloss ionomer. So it is an alternative to, even if I use limelight, I'm probably going to put Vitribond over the limelight. And I'm going to bring this back up. Here we go. Any other questions that I can answer for anyone? It's very odd doing this type of a presentation and not not being able to see your faces. So I hope everyone is doing well, and I hope you have enjoyed it. I will stay on here for at least another 15 minutes, if not longer, if anyone has any other questions, and I'm happy to discuss. I feel like I should break out some of those dance moves that Dr. Hauenstein was talking about. All right, so the question is, what is the prognosis for a traumatic injury to a primary incisor, let's say 3 years old, half coronal crown fractured off with large pulp exposure? So really the overall prognosis that is not really great. Now, if there's enough tooth that you can actually do a strip crown, then what I would do is I would do a pulpectomy, remove the entire pulp canal, put in a calcium hydroxide, so Vitapex, Diapex, and then do a strip crown over it. But I would do that as soon as I could. You can leave that pulp exposed because it should fibrose, and like CVEK says, should not be a cause for immediate pain. So, but the truth is, a parent is going to be pretty stressed if that pulp is exposed. So we really don't do CVEK pulpotomies on primary teeth. We typically do a full pulpectomy when there's a pulp exposure like that, and we'll kind of go from there. And then restore over it, typically with a strip crown. And just so you know, I've been communicating with Jeff, and so Jeff has, many of you have requested my email. Anyone who likes, please email me. If you don't want to ask a question on the chat, feel free to email me. Jeff, I will email you. This presentation that I gave today is actually a little bit more has more slides than the one that you originally put on your website. So I will send that to Jeff and he can post that. And if there's anything else that I can do, I'm always happy to talk over cases with you. If you get into a situation, talk over materials with you, please let me know. Since both dical and limelight are calcium hydroxide, why is it that only dical can be used for direct pulp cap, but not limelight? Limelight can. It does not have as favorable reaction. It's a little bit more acidic than dical, so it's not a great direct pulp capping agent, but you can use it. All right, Jeff, Phil, I think we'll sign off. People have my email. Please continue to email me with cases, with questions. I'm happy to help in any way I can. If you want any of the protocols that we use here at Cincinnati Children's, I'm always happy to share those with anyone. And please stay safe and enjoy the rest of your weekend. Thank you, everyone. Bye.